And it says it's recording, so we should be good there. Oh, I see people joining us. There's Gina. Hey, Gina, we see you in the attendee list. We're going to get you into the panelists. Sorry about that. I got her.
Okay.
Okay. Hello, everyone. Welcome. We're going to get started in a few minutes. We're just getting started here. We've got about 7 minutes, so thank you for joining us. And Gina, if you'd like to put your video on, we can make sure that works for you.
Okay.
Okay. Perfect. Hello.
Hi.
How
Is the lighting okay? Is that too bright?
it's a little bright, but I think.
How's that? Too bright?
I think it looks fine. I think you look great.
Okay, thanks.
Yeah, that's definitely better. You turned it down. That was good.
Mm-hmm.
So welcome. We're just inviting everybody in. We're gonna wait a few minutes to get started, but we're very excited. I think we had a couple extra questions pop up too, and I'm sure more will come in during the presentation. So we're looking forward to it.
Okay. And is my sound okay, Katie?
Yes.
All right.
Definitely. Does my sound okay?
It does. Thanks.
Thank you very much, Gina. Just wanted to say hello as well.
You're quite welcome. Thank you.
I really do appreciate your help with this.
My pleasure. Happy to help.
Joe, do you have the chat open in Whova so you can see everybody chatting?
In Hoover, I have to go into my app then. Hold on 1 second.
I have the Q&A open. More questions coming in.
Nothing in the chat right now.
Okay, great. Oh, I see Shane Morris is joining us tonight. Hi, Shane. And Sarah, some people that I know. Hello, Fran, Bridget, Abby. And some people, there's some names here I'm not familiar with yet. So welcome everybody. Very exciting to see new faces, or names rather, because I can't see your beautiful faces. This is very exciting.
So Gina, I don't know if you saw the email that, a few emails that have been going out. We have over 2,000 people that had signed up for the summit. So over these 3-week sessions, so.
That's wonderful. Congratulations to both of you.
Thank you. I think it was like 2,348 or something, Joe. It was a large number. It was very exciting.
This morning, yeah.
Very, very exciting.
I think the virtual format makes it easier for folks.
Well, it definitely does, give it an opportunity for people globally around the world to participate without having to travel. And so this is a real great opportunity for that.
Are there people joining from around the globe for this session? Or is it mostly US?
Can we see that in the chat, Joe? Or in Huva?
Ask in the chat, where is everybody from?
Shane says hi. Now I see the chat. By the end of this summit, we're going to be pros at Huva and Zoom. So we'll get started in a couple minutes. For everybody who's joining us, thank you for joining us. And if you'd like to put in the chat box where you are joining us from, we'd love to hear or read. Still learning how to use my chat box on Huva. I will probably not monitoring the chat box, but I think Joe will be. And be sure to put your questions in the Q&A box. If you have any, those will be answered in a separate chat. You'll see a box that says Q&A, and that's where you should put your questions. So I see Madison, Wisconsin, Staten Island, New York, Houston, Texas. We're also waiting for a hurricane here. Utah. Awesome. Very, very cool. So now we have 21 people. And I guess it's just about 7:30. Should I go ahead and get started? I think we've got like 10 seconds to 7:30. I don't think anybody is going to mind if we start about 10 seconds early. So hello everyone. If you don't know me, I'm Katie Wright. I'm the director of the VEDS movement. And on the call today, we also have Joe Grima, our Chief Scientific Officer, and Dr. Gina Adrales, who's going to be presenting and talking with you today. Before we view the presentation, I just wanted to let you know how excited we are that you're participating in this very first International E3 Summit with us, educating, empowering, and enriching our community. This is brought to you by the Marfan Foundation and its divisions, the Loeys-Dietz Syndrome Foundation and the VEDS movement, and our partners in Europe at the CERN. We are very grateful to our presenting sponsors, Brigham and Women's Hospital and American Communications Construction. Before we start the presentation, I want to let you all know that the International E3 Summit is a forum to provide an open discussion of issues related to genetic, aortic, and vascular conditions. Opinions stated in each of these talks are those of the speakers and not necessarily those of the Marfan Foundation or the CERN. So we are very fortunate to have Dr. Adrales here to present to all of you on gastrointestinal surgery and VEDS, or vascular Ehlers-Danlos syndrome. Before we go to the presentation, I do want to give Dr. Adrales an opportunity to say hello. So I'm going to pass it over to Gina to say hi.
Hi, everybody. Thank you for joining us tonight. This is my first time participating in this movement and international summit. I'm very excited, and I hope that I can provide some useful information.
Thank you, Dr. Adrales. So we're going to go ahead and take our videos off now so that we can play this presentation for you. So I'm going to turn off my video. Gina and Joe, if you'd like to turn off your videos.
Thank you very much for the opportunity to meet with you today. I'm Gina Adrales. I lead our division for minimally invasive surgery at Johns Hopkins, and I will be speaking about gastrointestinal considerations in vascular Ehlers-Danlos syndrome, or VEDS. This is my only disclosure. I serve on a Women in Surgery Advisory Board for Allergan. So today we'll be talking about GI considerations for VEDS patients. In about 70% of VEDS patients, the first symptoms would include a dissection of the vessels or a rupture, a gastrointestinal perforation of the intestine, large intestine or small intestine, or organ rupture. So there is a clear association between all subtypes of EDS and GI symptoms. For VEDS patients, colon perforation is the most common, and we'll go through some of those events today. I show this slide on the hypermobility subtype of EDS because there is some overlap between GI symptoms in this subgroup along with others. And this would include some functional GI disorders, namely chronic abdominal pain. There can be nausea or vomiting, acid reflux, and patients may have either delayed emptying of the intestine and the stomach or increased stomach emptying. There can also be some structural abnormalities we can see in this subtype as in others, such as diverticulosis, which you can see in the hypermobility subtype as well as in VEDS, and other issues such as hiatal hernia or ventral hernia. And in addition to VEDS, the subtype can also see GI bleeding. But our focus today is really symptoms that can happen in the digestive tract for VEDS patients. That could include spontaneous bleeding of the GI tract. It could include organ rupture of the intestine, liver, or spleen. Patients with VEDS have a high risk of surgical complications. They also have a risk of developing hernias from those surgical incisions or having a recurrent hernia after that hernia is repaired. Patients with VEDS also can develop diverticulosis or outpouchings of the wall of the colon, which could then place them at risk for rupture or bleeding. I share with you two series here, long-term series, first from the Mayo Clinic of 67 patients over 24 years who studied VEDS patients to see what symptoms are very common. About 2/3 of the patients present with abdominal pain, and about 40% of patients experience nausea, heartburn or reflux, or constipation. In another series of 133 patients over 17 years, there were 112 digestive events experienced in 55 VEDS patients, and more than half had a second event. Of these, the most frequent included perforation of the colon or rupture, as well as spontaneous spleen rupture, but that remains fairly rare. Slightly more than half of GI patients did not have a perforation, but experienced bleeding or ileus, which is more of a paralysis of the intestine, which can act like a bowel blockage, the same with pseudo-obstruction or organ rupture. What are some considerations if VEDS patients need to have surgery? The most severe problems are seen among patients with the vascular subtype of EDS. VEDS patients not only have a higher rate of need for surgery, whether that includes organ rupture, which can happen in up to 25% of patients. Compared to other subtypes, VEDS patients also are 3 times more frequent to need GI surgery. Not only do VEDS patients require surgery more often, but they're also at greater risk of surgical complications. There can be excessive bleeding, which is seen in over 1/3 of patients. They may experience poor wound healing. They may also experience recurrent rupture or tears of the arteries, bowel rupture, or hernia development. While celiprolol is a new medication that may help prevent arterial complications in VEDS patients, we don't know much about its effect on the GI complications to see if this is also preventative. When is GI surgery needed in VEDS patients? Well, when there's non-invasive treatments of surgical diseases that don't work, or if there is an emergency where there's rupture of the intestine or the stomach, where there's spillage of contents into the abdomen, and this can cause a severe infection. Or when there's bleeding from the digestive tract that can't be controlled by other means. Or if there's a hernia that's symptomatic, meaning that there's symptoms of a bowel blockage. And so it forces us to consider hernia repair. If VEDS patients need to have surgery, then the providers and the patients should think about ways to try to prevent complications. This would include avoiding medications that increase the risk of bleeding. In general, when patients present for surgery, we often give them a medication to help reduce the risk of forming blood clots. But in patients with VEDS, we might consider avoiding that because of the potential risk of bleeding. We have to be careful about positioning. Some patients may be prone to dislocation or joint hypermobility. And so we have to be careful when we place the breathing tube for general anesthesia. We also have to think about the IV lines that we place. Sometimes with certain surgeries, we might want to place a monitoring, a larger IV line in the neck, for instance, or under the collarbone. But these veins are located close to large arteries as well. And so we try to minimize the use of this type of IV because of the risk of injury to the arteries. When we close the muscle wall on the abdomen, we have to be careful and make sure that we're doing this well to try to reduce as much as possible the high risk of hernia that VEDS patients have. If VEDS patients have had prior surgery, we know that there can be severe adhesions from the prior surgery, and so this may lengthen the time of the surgery that's needed because of these adhesions have to be taken down. So altogether, this requires significant planning when possible with vascular surgery. Hematology or rheumatology may be involved, as well as anesthesiology. Again, we avoid the medications that might affect platelet function. This might not be just those that help prevent clotting, but also some antibiotics and other medications for acid reflux might affect platelets. In some patients, we might decide to use desmopressin to help prevent bleeding. And then sometimes for patients who need a big abdominal surgery, we might advocate for an epidural to help with pain control. But we have to carefully consider this in VEDS patients because of the risk of bleeding at the site and as well as the decreased effect that this type of administration of pain medication might have. The fragility of the tissue warrants careful handling in the intestine, and because of the risk of poor wound healing, there is a higher risk of developing a hernia at the time of surgery. The increased risk of bleeding requires meticulous control of bleeding vessels and tissue during surgery. And so because of the high risk of surgery and anesthesia, all options should be considered prior to surgery, including non-surgical treatment. This isn't always possible, and we'll talk about some of the surgery considerations today. Surgery is needed when there is intestinal rupture in VEDS patients. The most frequent type of rupture would be that in the sigmoid colon or the lower part of the colon, and this happens in about 80% of patients with VEDS who present with intestinal rupture. A smaller proportion, about 20%, may present with rupture of the small intestine, and even more infrequently is a rupture of the stomach. In VEDS patients, about 80% of GI complications are due to spontaneous GI perforation, namely in the colon. The mean age of first occurrence is 24 years. Intestinal rupture is rarely fatal, only seen about 3%, but there could be bleeding or artery rupture during the surgery that might be serious and require other intervention. Constipation can be a risk factor for perforation. So when we think about ways to try to prevent surgery or limit the risk for surgery, we should address constipation in VEDS patients. Typically, this requires a bowel regimen with laxatives and a high-fiber diet that has been shown to be beneficial. A high-fiber diet is helpful even in the general population to reduce the risk of diverticulosis. Patients who have chronic constipation or are straining to go to the bathroom may develop diverticulosis or develop something called rectal prolapse, where the rectum tends to push out of the anal area. That sometimes can require surgery. So addressing the constipation can be a preventative measure. We should, though, avoid enemas in VEDS patients due to the risk of perforation. In addition to this, some VEDS patients may have chronic pain, and we know that opioids can increase the risk for GI symptoms, whether that's nausea, decreased motility of the stomach or intestine, or constipation. And so, if possible, these should be avoided. If colon rupture occurs, it tends to happen in the sigmoid colon. Most are treated with removal of the ruptured colon and an ostomy. And this is the same type of treatment that we would offer patients who do not have VEDS or other subtypes of VEDS. The affected colon is removed, and an ostomy, where the bowel is brought out through the stomach wall or abdominal wall to drain the stool, is made. Young patients might then, after that emergency event, prefer to restore the continuity of the digestive tract. So instead of having an ileostomy or a colostomy, then this can be restored. However, this shouldn't be considered until at least 3 to 6 months after the initial operation. There are different things that can happen depending on the amount of colon that has to be removed. And with that, there's different risks in terms of repeat perforation or leakage if the intestine is reconnected. So if the entirety of the colon is removed, then that decreases the risk of repeat perforation. So if you look at the risk of repeat perforation after removal of the colon, it's about 2.5 times higher after reconnecting the intestine rather than just having an end ileostomy. And that statistic is shown there of a 67% risk of repeat perforation versus 27%. And I'll go into this in more detail in the next slide. There is a risk of death reported up to 66% if there's a leak after that ostomy is taken down. And so restoring that connection of the intestine has to be carefully considered versus the impact of quality of life with living with an ostomy. VEDS patients might have widespread diverticulosis or some outpouching of the colon. So you can see that in the picture. Where the wall of the colon becomes weak. There's a lot of collagen within the colon wall. And so where there's a collagen deficiency and the wall is weakened, it can pouch out through the muscle of the colon, and that is a diverticulosis. So normally we see most of that diverticulosis in the lower part of the colon or the sigmoid colon, and that's why ruptures are common in that area. But it could be widespread throughout the colon. And so if it is widespread, then you might consider removal of the entire colon to prevent a repeat rupture. So let's look at the different options for colon surgery. On the left side, you see the intact digestive tract, including the small intestine and the large intestine. In the center pictures, this shows at the bottom the removal of the sigmoid colon and the creation of a stoma or ostomy. So about 3/4 of the colon is still present, and it now drains through a connection made of the stoma out through the abdominal wall. In the picture above that, you can see how the colon has been removed, but the rectum and the remaining colon are reconnected. And so in that procedure, compared to an ostomy, it relies on good healing between the rectum and the remaining colon, and there is potential for leakage of that area. What are some risks of having a stoma? Well, the stoma is brought out through the abdominal wall, and so you could develop a hernia around that site. Patients then have to deal also with the lifestyle changes associated with that. You can lead a normal, healthy life with a stoma. It's just that the stool drains through the bag that has to be changed and emptied each day at various times. And then the pouch tends to stay on about 3 days at a time. But sometimes you can get some leakage around that pouch and some skin irritation as well. On the far picture on the right side, it shows how the entire colon has been removed. And in the bottom picture, again, it brings out that lower part of the small intestine through the abdominal wall that drains. On the picture above that is just one configuration of how the small intestine can then be reconnected to the remaining rectum. What are some downsides of this? Well, again, you have to ensure that that heals well. And if that doesn't heal well, a patient can get very sick. And that those symptoms are very similar to just presenting with a spontaneous rupture of the colon. You can develop a serious infection with that. It may require other surgeries. In some cases, it can be managed just with drainage and antibiotics. Because the colon works to absorb a lot of the fluid that we take in, when that's gone, the stool that drains from the small intestine is much more liquid. And so patients who have this connection will experience more frequent bowel movements, sometimes 6 to 8 times a day. Sometimes they have to get up at night a few times to empty their bowels as well. So depending on the type of connection that's made between the small intestine, whether a pouch is made and then connected to the rectum, or if it's just straight connected to the rectum as shown in this picture, there can be issues related to the bowel movements. But for this type of surgery where all of the colon is removed, you then also remove the risk of having a repeat rupture of the colon. And so there is that advantage with this type of surgery. So when you look at the risk for perforation after colon surgery in VEDS patients, we know that there can be a repeat perforation, and that happens at a median time of 2 years after the first operation, but it can range anywhere from 0 to 120 months. When the colon is reconnected, the leak rates are high, ranging from 14 to 17%. This is compared to a general population where that number typically is less than 5%, depending on the type of surgery that's done. There seems to be a greater risk of repeat perforation after removal of just a portion of the colon with reconnecting versus removing the entirety of the colon and connecting the ileum or the small intestine to the rectum. And you can see the difference in numbers there for 55% risk of repeat perforation of the remaining colon versus 7% risk of intestinal rupture. What about small intestine rupture in VEDS patients? This is much less common than colon rupture. Typically, when there's a leak like that, surgery is required. The only exception to that may be if somebody were having an endoscopy procedure done where there's a camera passed into the digestive tract and there's a very small visible rupture in the wall of the intestine. And that might be handled just with drainage if needed and antibiotics and bowel rest. But for the majority of patients, surgery is required to remove that affected segment of bowel that's perforated and then reconnect the intestine. And the diagram shows a picture of this being done. Unlike colon surgery, the risk of leak from this connection is really not higher than in the general population. And so typically the bowel is reconnected rather than having an ostomy made. But there can be exceptions. What about GI bleeding? There can be bleeding in VEDS patients that can affect the digestive tract, whether that's affecting the vessels that go to the intestine or the splenic arteries. 7 of 100 patients may experience GI bleeding, which can present as bloody vomiting or bloody stools. If patients with VEDS who have ulcers, those ulcers can be at increased risk of bleeding. And sometimes patients may develop a spontaneous hematoma or a thick bruise in the wall of the small intestine. And that might present as bowel blockage symptoms and typically wouldn't require surgery, but just some bowel rest and perhaps a drainage tube to allow the stomach and intestine contents to drain as that hematoma heals. Occasionally, endoscopy might be needed in VEDS patients, and this would require very careful positioning due to the tissue fragility and possible joint dislocation if patients with VEDS are also hypermobile. The risk of perforation in VEDS patients approaches 10%, and this is much higher than in the general population. But when you look at colonoscopy in VEDS patients, it is higher than other patients who might have other connective tissue disorders, regardless of whether there's diverticulosis or not. For this reason, non-invasive methods of colorectal cancer screening is recommended, whether that's imaging, Cologuard, or other methods of stool testing. Now, if somebody with VEDS has a high risk of colorectal cancer in their family, such as a first-degree family member who has colorectal cancer, particularly at a young age, then colonoscopy may be warranted. But for folks who have a normal cancer risk, then non-invasive cancer screening may be sufficient. What about stomach surgery in VEDS patients? Sometimes patients have endoscopy and don't realize that they carry a diagnosis of EDS of any subtype, but may find that they have this outpouching of the stomach wall, which is typically an unusual occurrence, and this may trigger a raised suspicion of the diagnosis of EDS. Spontaneous perforation in VEDS patients is infrequent. It's usually triggered by an intervention such as endoscopy. For patients who have acid reflux or symptoms of delayed stomach emptying with nausea, vomiting, and bloating, the medical therapy should still be the first-line treatment. I take care of a number of patients with gastroparesis, and in my opinion, there's not much in the literature about this topic in VEDS patients, but in my opinion, procedural interventions for gastroparesis are not recommended because of the risk of rupture. That's because the interventions that we have to offer patients with gastroparesis all involve some manipulation or opening of the stomach wall. That would include whether we split the muscle at the outlet of the stomach or actually open up the stomach and first part of the intestine and then close it back again to widen the outlet of the stomach, or whether we implant electrodes into the wall of the stomach with a gastric neurostimulator. There is still risk of poor healing at the site or a rupture. And so that's why, in my opinion, I don't recommend interventions such as this for gastroparesis in VEDS patients. I shared this slide with you to talk about hernia. Patients with VEDS are at higher risk of developing a hernia if they need surgery. And this speaks to the underlying collagen disorder. We know in general, whether patients have VEDS or not, if they have an abdominal aortic aneurysm, those patients are at higher risk for developing a hernia. Overall, if we talk about patients, whether they have VEDS or not, and have a hernia, the risk of having a hernia emergency, whether it's a bowel blockage or a bowel that is threatened because it's protruding out through the abdominal wall and it affects the blood flow, the risk of having an emergency like that is low. On the other hand, having an emergency hernia repair is always associated with a higher rate of complications than planned elective surgery. So if patients with VEDS have a hernia and they're having symptoms of a bowel blockage, as is intermittent pain or firmness of their hernia associated with some nausea or other symptoms of bowel obstruction, then a planned hernia repair is probably wise. If VEDS patients need abdominal surgery for other reasons, whether that's for an aneurysm or a spleen rupture, then consideration should be given to putting mesh in at the time of that abdominal wall closure to strengthen that abdominal wall to try to reduce the risk of hernia development. Mesh should be placed, though, only in patients who are having clean or non-contaminated abdominal surgery, meaning surgery that doesn't involve the intestine, particularly the colon, because of the risk of infection. But this may, if placed, may help prevent the development of an incisional hernia at the site that might require another surgery. So in conclusion, surgery in VEDS patients is associated with a significant risk of bleeding, leak, and other serious complications. And because of this, surgery should only be performed if deemed absolutely necessary or if other less invasive treatments have failed or aren't feasible. We should take efforts both on the patient side as well as the surgery and anesthesia side to try to avoid injury and to limit risk as much as possible. This would include careful positioning, particularly with the induction of anesthesia, avoiding medications such as antibiotics or medications for clotting that might affect platelets and clotting and thus increase the risk for bleeding, carefully handling and protecting the skin, the intestine, having good bleeding control during the surgery, and being careful with the abdominal wall closure to try to prevent as much as possible the development of an incisional hernia. The extent of surgery for GI perforation, such as in the colon, should take into account the risk of leakage if the colon is reconnected, or the risk of repeat perforation, whether that is to remove just a portion of the colon or all of the colon. I thank you for the opportunity to talk with you today about GI considerations in VEDS patients, and I'm happy to take any questions.
Great. So thank you so much, Dr. Adrales, for preparing that presentation. Just a reminder for everybody, there is a Q&A box where you can submit your questions. I know that we have quite a few, so we're going to go ahead and move right on into the Q&A. And there were some submitted ahead of time, so I'm going to start with some of those, Dr. Adrales. So for someone with VEDS who has perforated their colon twice, resulting in 95% of their colon removed with an ileostomy, I think you talked a bit about this risk of the ileostomy reversal. Would you say that that reversal outweighs the benefits? Like the risk outweighs the benefits in that case?
I think you'd have to really strongly consider that and have a thorough discussion with your surgeon about it. As you saw, when you do the reconnection, with any colon surgery in a patient with VEDS, the risk of having a leak when it's reconnected is higher than normal. So while the majority of patients might do fine, there's going to be at least up to 17 out of 100 people that will have a leak. And of those patients who leak, the risk of death is very high. 2/3 of those patients are going to die because of that complication. So I think it has to be carefully considered, and to think about the reasons of why you'd want to get reconnected. So if it's just if it's issues dealing with the stoma that can be managed either by different pouching or working with a wound care or ostomy specialist, then I would try to do that. Or if it's problems in terms of, let's say there's some colon left when it's not this situation where 95% of it has been removed, but there are other issues of malabsorption. So when the small intestine is draining fluid, there's a lot of fluid loss and some electrolyte loss. And so if there is some colon left and you can reconnect that, then it might address some of those issues. But in this situation, when the majority of the colon has been removed, to take down the ileostomy, I think, is fairly risky. So I would just consider that carefully. The other thing to consider too is that with a stoma, having the bowel movements like that is fairly, it can be a controlled situation, though it is sort of a life, quality of life issue. You still can control it in a way. Whereas if you're reconnected, you can have multiple frequent bowel movements, as I mentioned. So depending on how that small intestine and the remaining rectum are put together, you might still end up having, 6 to 8 bowel movements a day. You might be getting up at nighttime, a few times at night to have a bowel movement. So that also can affect the quality of life.
Thank you. So our next question has gotten 5 upvotes, and I think I have the same question. You talked a bit about managing constipation and motility issues in patients with VEDS. And we want to know, does taking fiber and Miralax and Colace really help prevent bowel perforations? Or do you still see people have bowel perforations with VEDS who are taking these supplements and successfully treating their constipation and motility with them?
I think the benefit of having regular bowel movements, and that can be supported by a good fiber inclusion in the diet or a fiber supplement. I think the benefit is really reducing the risk of constipation and reducing the risk of developing those little outpouchings of the colon or the diverticulosis. So the diverticulosis itself can be a source of a rupture in the colon. And so that's really sort of the main goal to do it. Can you still get a perforation whether you're on a bowel regimen or not? You can. Just like, folks in the general population without VEDS can also get diverticulosis and have rupture too. But I think if you are looking overall at the risk of, surgery and the risk of perforation, including fiber in your diet is a fairly straightforward thing to do. Now, in general, in non-VEDS patients, I really don't recommend daily laxatives. Laxatives themselves can, are stimulating for the intestine, and it's possible that your intestine can then get used to it. So then it's really hard to have a bowel movement. But things like Miralax, fiber supplements are healthy to take, every day.
Thank you very much. I think you talked a bit about abdominal pain earlier in the presentation when you were talking about the study that you did. For a child with a confirmed diagnosis of VEDS who complains often of abdominal pain, cramps, and tightness, should these be considered emergency situations, and how can we be sure the pain is not related to an imminent spontaneous rupture?
That's a very good question. So if it's sort of intermittent abdominal pain or crampy abdominal pain, then it may just be some irritability of the intestines or irritable bowel syndrome or constipation. But if you add on top of that more worrisome symptoms of a rupture, such as a fever, pain that persists and is not going away or is getting worse, especially if accompanied by a fever, a higher heart rate, in a child, some look of distress or vomiting, then those patients should seek medical care.
Thank you. So for someone who had a perforated stomach repaired with mesh 10 years ago, what alternatives to endoscopy can be used to monitor the severity of ulcers that are continuing to develop around the scar tissue? Are there any?
So I'm just going to backtrack a little bit on that question. In terms of ulcers of the stomach itself, typically evaluation would only be necessary based on symptoms. So if somebody had a history of stomach ulcers and then we're having abdominal pain again, especially in the upper part of the abdomen, that you would be concerned about having a recurrent ulcer, then an endoscopy could be done as an alternative. A X-ray study that's called a fluoroscopy study, also known as an upper GI, where you swallow some dye and they get serial X-rays, can also help outline an ulcer. But if there's any concern of a perforation, then doing an upper GI wouldn't be the first test, because you wouldn't want that contrast to leak through the stomach, through that opening. A CT scan might be safest if it's an acute or emergency issue. Typically for a ruptured stomach or perforated ulcer of the stomach itself, we wouldn't put mesh there. But you would use mesh if you were repairing a hernia, like in the muscle wall or a gap in that muscle wall. So I'm not sure how to answer that question. If there was a hernia with a mesh repair, again, no real need to get serial CT scans to check that. It would really be based on, an exam or evaluation. So just your regular checkups with your doctors would be sufficient. And if there were a concern about a recurrent hernia, then a CT scan or MRI would be appropriate.
And that leads right into, we have quite a few questions here about hernias. So several people have huge problematic hernias. One person says, what could be done for one that is too big for a mesh fix for people who also have spondylosis and stenosis?
Hernias can be challenging, especially when the risk of developing another hernia is fairly high. So one thing to approach if you're thinking about having a hernia repair is to try to manage other risks that might increase the risk for surgery. For instance, if somebody with VEDS also had diabetes, then you would want to make sure that the diabetes is under good control, so that hemoglobin A1C is around 6 or 7 or less. And so because diabetes itself can increase the risk of hernia recurrence or poor wound healing. If a patient were overweight or obese, that also increases the risk of getting a hernia and increases the risk of the hernia coming back again. In terms of fixing the hernia, a mesh repair certainly tends, not just in VEDS patients, but in the general population, tends to reduce the risk of the hernia coming back again compared to just bringing your own tissue together. Ideally, we try to do both, where you bring the tissue together and then reinforce that muscle wall with a mesh patch. and try to do so where we separate that or have like an adhesion barrier so the mesh isn't in direct contact to the intestine to limit any scarring there. So it's, I think the hernia, there are a number of different ways to fix a hernia, and that would be something that probably you'd want to see a hernia specialist, hernia surgeon for, so that they can go over all the options with you based on sort of the shape of your hernia, the size, and what other prior repairs you might have had or prior surgeries that you might have had. So it's a very individual treatment, I think.
Okay. So going back to diet and general GI symptoms, we've got a couple of questions here that I think are very interesting. So one person is asking if you can speak more about the recommendation for high fiber. They were told that fiber actually bulks you up, and then with previous GI issues, the fiber is hard to get rid of. Should a low residue or high fiber diet be followed in that case?
Now, there may be circumstances where you wouldn't want to take an extra fiber supplement for that. So for instance, if you had prior surgery before, there might be a reason for your doctor to recommend against a higher fiber diet. If you, have ongoing problem, if you've had a narrowing, for instance, in your digestive tract for some reason, whether that's because you've had prior surgery or a rupture that's scarred, then that would be another reason to maybe avoid, bulking up your stools with extra fiber. So again, it would be something that probably you'd want to talk to your physician about for your individual situation to see if it's applicable to you.
And what about for patients who experience a lot of bloating? Do you have any recommendations for that?
So there are some patients who have sensitivities to various foods, whether that's, lactose and dairy products, for instance. Some patients will have bloating or crampiness related to, because they can't tolerate certain sugars in the diet well. So there is a certain diet called a FODMAP diet. If you just, look it up on the internet, you can come up with various diets, but it talks about lowering the amount of fructose in particular in your diet. And there are certain food triggers for that. So sometimes that can be associated with bloating. And there can be other reasons for that as well, whether that is because of constipation and, and fullness of the colon, or it could also, bloating can be a symptom of gastroparesis or delayed gastric emptying.
Thank you. So for someone, we did have somebody join us tonight who has Loeys-Dietz syndrome, which is a related condition. And they have an incisional hernia that developed following surgery for an abdominal aortic aneurysm, like you had talked about. When should the hernia be operated on? Can a surgeon with no experience with Loeys-Dietz do it? And is the procedure different in a patient with Loeys-Dietz?
So a surgeon without experience with LDS can do the surgery, but I certainly would recommend somebody who has done, a lot of hernia repairs and is comfortable with complexity of it. Patients with LDS or vascular EDS or patients with aortic aneurysm in general have a higher instance of developing a hernia. And so they also have a higher instance of developing a hernia again once it's repaired. So it does require some particular care and meticulousness in repairing the hernia, not just in how you, stitch it closed, but the technique that you use and the application of mesh, when appropriate. So it's really, that should actually be no different for someone with LDS or not, or VEDS. We want to make sure whenever we do a hernia repair that we do it, very carefully. But there can be extra precautions we have to take. For instance, sometimes there could be really tiny capillary, like little vessels that might bleed. And in a patient without those conditions, it would be something that we could just use cautery and not put ties on to take care of it. But in somebody who has a higher risk of bleeding, even those really tiny small vessels, you have to either clip them or tie them or something to reduce the risk that you could get a lot of bleeding accumulating from multiple little vessels that are bleeding. There also needs to be some special consideration about the medications that we might use. As I mentioned, very often we're giving medication to help produce blood clots, but in certain instances we might avoid that and use other means to try to reduce the risk of bleeding. And being careful about certain other medications that might affect platelet function as well. If you're having surgery, and again, this is something, I think the diet is worth some consideration as well, whether that is just to, eat a nice healthy diet to keep your digestive tract as healthy as you can. But there's also a lot of people take supplements, and there really isn't great regulation of that. And a number of supplements, even things as benign as like ginger, can increase the risk of bleeding. And so you definitely, if you're going to have surgery of any type, you want to disclose those supplements to your surgeon and doctor and let them know what you're taking, and just ask if that's something you need to stop before surgery.
Thank you. So going back to colonoscopies, I think you did talk a little bit about alternatives to colonoscopy and when an alternative to colonoscopy is not appropriate, particularly if there's a risk of colorectal cancer. So what precautions need to be taken if a colonoscopy is indicated in somebody with VEDS? Could you go over that again?
Yes, I'm sure, the gastroenterologist or colorectal surgeon or surgeon who's doing the colonoscopy needs to be aware of the condition. Sometimes folks can have a really curvy, tortuous colon, and because of that, it can be challenging to do a colonoscopy. In some instances, the person who's doing the endoscopy might be able to get past that, but I think that person has to have some, a lower threshold to stop. If it's hard to get around, then the alternative then for a colonoscopy is to do an X-ray study with contrast. Again, that has to be a low pressure study because an enema can increase the risk also of a rupture. In patients that have a higher risk of cancer, then a colorectal screening with an intervention like that is appropriate. One still might start with a different type of stool testing. So there are various tests that are out there now. I mentioned the FIT testing that basically is checking the stool. It's like an immunochemical test that looks for occult blood. And, we used to just test the stool samples for blood, and that would give us an indication of whether there was a risk of cancer there. But in this case, it's a DNA test of the stool. The Cologuard also is very similar, so it checks for blood in the stool in this way, but it also checks for other markers that can be associated with colon tumors. And so both of those can be used as a first-time screening, and if there's a concern of the test, because there can be some false positive tests, especially the Cologuard, where it looks like it's abnormal, but it actually is normal. It just is testing abnormal. And so in those cases, you may want to follow it up with a more in-depth, like a colonoscopy. So anyway, there are a number of different options now that are available besides colonoscopy, especially for someone who's not at increased risk for cancer.
And for someone with VEDS who sees a gastroenterologist who recommends a colonoscopy or endoscopy and is not familiar with VEDS, was there specific wording you would recommend to help the doctor kind of realize the significance of the diagnosis of VEDS? I think some people frequently kind of come up against a barrier there.
Yeah, I can see the challenge. It's sometimes hard to really, express the risk or concern that a patient might be having and to feel like you're heard. So I think if you just mention, I have to say again, your diagnosis, I have VEDS or Louis Dietz, whatever, whichever that may be, to say I have this, and I've, heard of others having, that it can increase the risk of rupture. And so can you tell me a little bit more about that? Are there alternatives? Whenever we are, whether it's doing an endoscopy or a surgery procedure, it's our duty as the physician to talk to you about, why we should do it, what the benefit is, and then also the risks. But not just that, are there other alternatives? And so it certainly is within your right to just ask about that, to point out, this is what I have. I know it can be associated with an increased risk of rupture and a bleeding risk. Can you tell me more about that? And make sure that you're comfortable and you have all your questions answered.
And then what would you recommend if you don't feel comfortable after that conversation? Anything?
If you don't feel comfortable after that conversation with that physician, let's say you ask those questions and you're not comfortable with proceeding with that study, you can always decline and say, well, if I really don't want to do this, I'm worried about the risk. Is there something else we can do instead? That might be an approach. If you're really not comfortable with that particular physician, then you can just step back, I think, and talk to your primary care physician and see if there's somebody else that they might recommend, and express your concerns to that provider that you trust.
Thank you. I'm sure that's going to be very helpful advice for a lot of people, especially the recommendation to, ask them to tell you the risks. I think that's a really great approach there. For somebody with VEDS who has had C. diff a couple times and whose GI doctor is trying to rule out ulcerative colitis, how does living with VEDS and ulcerative colitis work?
So ulcerative colitis it's a disease, inflammatory disease of the colon. It can be associated with other, associated illnesses, not just in the GI tract. And typically we would treat ulcerative colitis or like Crohn's disease with medications to suppress certain aspects of the immune system. For ulcerative colitis, as opposed to Crohn's, it's really isolated to the colon. And so if there can be, some folks think there's a spectrum between Crohn's disease and ulcerative colitis. So there can be folks that fall in the middle where you're not exactly sure of the diagnosis, but people who clearly ulcerative colitis, it can be actually curative to remove the colon. At the same time, in somebody with VEDS, if there's a concern about rupture or other complications of the ulcerative colitis, then certainly surgery can and should be considered. Now, it is high risk, as I mentioned, but I think if there's a careful approach and if you weigh the risks and benefits and you feel like that's right for you in discussion with your surgeon, removal of the colon and ileostomy is, something to consider if that's indicated. Otherwise, it's usually just a medical treatment where some people can have mild ulcerative colitis and other people can have complications related to ulcerative colitis, such as a lot of fullness or bloating in the colon, rupture, bleeding can happen. And so if you have any of those symptoms or complications of ulcerative colitis, you should consider surgery. But if it's mild, then the medication might be safest. So again, it's a discussion with your gastroenterologist or colorectal surgeon about treatment.
Okay. We have quite a few more questions. We're going to try to get through them, but any questions that we don't answer tonight, there will be an opportunity for you to submit them again. So don't give up if we don't get to your question. For someone who's developed a heavily pulsating feeling on the area of a known small indirect inguinal hernia, could this be pulsation from the hernia pressing on their femoral vessels, a sign of a new aneurysm? Is this something that they should be worried about?
I think it's something that should be evaluated. So an inguinal hernia and a femoral hernia can sometimes be difficult to distinguish on exam. And an imaging, like an ultrasound, can be a simple, straightforward test to do. With the ultrasound, they can also check flow through that area, so for the vessels, so it could help distinguish whether there's an aneurysm there versus an actual hernia. A hernia in general typically would be reducible on exam, so if someone examined you, they would be able to tell that it was a hernia by reducing it, and should be able to distinguish if it's a femoral hernia because it would be just adjacent to your femoral vessels. Whereas an aneurysm, will be pulsating, has a little different feel to it, and shouldn't reduce or push back in.
Okay. Could you speak to the risk of perforation for related connective tissue disorders to VEDS?
I'm not sure. So do you mean what is the risk for perforation compared to other connective tissue disorders?
I think the question is perforation a risk as well for related conditions like Loeys-Dietz, Marfan syndrome? For people with related connective tissue conditions, are they at high risk for perforation as well?
VEDS is certainly, there's a known risk for that. In patients who have other connective tissue disorders or I guess it's not as well studied. We do know in terms of hernia that there's an associated risk of hernia and aortic aneurysm, Loeys-Dietz, as well as VEDS. But in terms of GI perforation, like a colon perforation or intestinal perforation, I don't think that's well studied in other connective tissue disorders, or that the incidence is that high in other connective tissue disorders.
Okay. So for someone who has had multiple surgeries from VEDS complications, I guess they usually insist on giving him injections of heparin during his hospital stay. And I think you spoke a little bit about this in your presentation on avoiding medications that can, inhibit clotting. Would you say he should be avoiding this medication due to his diagnosis of VEDS?
I'm sorry, Kay, what was the name of the medication? At first, I missed that at the beginning.
It was heparin. Oh,
yes. So heparin, usually we would give that to help prevent blood clots, and we give it, at a higher dose, it can make the blood quite thin, so that there's a risk of bleeding. But the dose that we normally give to help prevent blood clots, it shouldn't be enough where it would increase the risk for bleeding. However, in patients with VEDS or LAS, they might have would have a higher risk of bleeding in general, and so you have to just weigh the risks and benefits of that. And in general, we may use other means to try to reduce that risk of bleeding, such as mobilizing early. Sometimes we may put little not too tightly, but little massager sleeves on the legs to help reduce the risk of bleeding, risk of blood clots, as opposed to a heparin dose. And there's different dosing that we can give for heparin or Lovenox. And so if that is thought to be a benefit, we would give it on the lower end rather than a full dose.
Okay. Do you have an opinion on alternative or osteopathic remedies to help minimize the risk of rupture in young children confirmed with VEDS?
I'm sorry, but I can't really speak much to that. I'm not, I don't have that much knowledge about the alternative therapy, especially for children.
Okay.
I don't take care of children in my practice.
Okay. So we will probably ask one more question then for tonight. You did speak to this a little bit. I want to make sure that we all understand. So for someone with VEDS whose sigmoid colon perforated and it healed on its own, would you say that they're at an increased risk to perforate in the same spot again, or is it just generally the colon is at risk for reperforation?
That's a good question. I think it depends on what the underlying problem is. So if it's a sigmoid perforation, and it was just able to be managed with antibiotics, I would bet that the diagnosis there would be diverticulosis, so that outpouching of the wall of the colon. And often those diverticula aren't, they aren't just single areas, they're in multiple areas. And so you can develop a, another rupture at one of those other sites. But in general, the diverticula tend to be concentrated mostly at that sigmoid colon. So on one hand, it might not be that exact spot, but it typically would be within that same region of the colon.
Okay. Well, thank you so much for presenting on this topic and for answering questions for our community. I know that this is a very hot topic in our community, and I know that we all really appreciate it. If your question was not answered tonight, please submit it to us through our website, marfan.org/E3ask. And be aware that we are receiving a high volume of questions from this E3 Summit, so it might take longer than usual for our Help and Resource Center to get back to you, but we will definitely get back to you. We'd also very much like your feedback on this session, so if you could complete the survey in the app, in the Whova app, that would be wonderful, and we hope you continue to take advantage of sessions throughout the summit. This is the very first day, so you have many sessions ahead of you and many opportunities to connect with other people through the app. If you can share your experience and what you've learned on social media, you can also use our hashtag E3Summit20. Thank you again, Dr. Adrales, and thank you everybody for joining us. I know that we're so excited to learn from you, and we very much appreciate your time.
Thank you very much, Kay. It was a pleasure. I hope it was helpful.
Thank you. I know it was for me. I very much enjoyed it, so thank you. And everybody have a great night. Okay. I'm not sure if we are still, I hit stop sharing, so I don't know if they can still see us or not, but I'm going to go ahead and end the meeting just in case. But thank you again, Dr. Adrales, and I really do appreciate your time with us tonight.
You're welcome. It was my pleasure. Thanks for having me.
Have a good night.
You too.